And welcome to this afternoon's Gecko session. Gecko is hosted by the Gastro Foundation in association with Project ECHO from the University of New Mexico. We've in fact had the pleasure of hosting Professor Sanjeev Arora, who is the founder of ECHO in South Africa over this past week. And it's been fascinating working with him and collaborating with new opportunities. Gecko sessions are held on a weekly basis on a Wednesday afternoon. We've had 49 registrations for this Gecko pathology session from 11 countries. And I'd like to extend a welcome to all of you to this session. Prof. Martin Hale will be taking us through a discussion regarding autoimmune hepatitis, and we have a number of interesting cases to share with you. Prof, I'll hand it over to you. I just want to see, have we got Dr. Petizai Machichwa online as well? Because I think he's going to be presenting one or two of the cases. Pat, are you here?
Yes, I'm on. Afternoon, Dr.
Fantastic. Afternoon, Pat. Welcome, and looking forward to you. Prof, Mr. BV, I think is our first case.
That's correct, Bilal. Yes. Yeah.
All right. So this was one of my patients. So I'm going to discuss this gentleman. He is a 52-year-old male, relatively healthy. Known with hypertension, for which he is on lisinopril and nifedipine, so that's an ACE and calcium channel blocker. He had a positive travel history to a rural area in South Africa. He went on holiday to the Bushveld, where he stayed in a lodge. No history of any arthropod bites that he could pick up. And certainly we found no eschar on clinical examination. This was the month before his presentation, and when he presented, he complained of arthralgia and general malaise. He'd gone to see his general practitioner, who'd done a urine dipstick and found bilirubin, and then noticed he was jaundiced and referred him on through to us. We found him with a marked hepatitis, transaminases of over 1,000, and a bilirubin level of about 70. His workup for viral hepatitis was negative. CMV, EBV, HSV, PCRs, all negative. Rickettsial serology was done and was also negative. In terms of his autoimmune markers, his ANA was negative, ANCA, smooth muscle, and an extended autoimmune profile all came back negative, but total immunoglobulin was elevated at 27. Normal is, our upper limit of normal is 16. This raised the possibility of an autoimmune hepatitis, and seeing as we had negative serology, we did a liver biopsy, for which Prof. Hale can take us through.
So thanks, Bilal. So what I'm going to do this afternoon is present a series of patients with autoimmune hepatitis, and really just try and develop a theme during the course of the presentation, and really show you how varied autoimmune hepatitis can be from a histopathological perspective. And we know, in fact, that it can also be very varied from the point of view of its clinical presentation, as we've already heard from Bilal. So this particular biopsy then, I'll just share the screen. So you should be able to see the full screen now. Can you see that, Bilal?
Yes, we can.
Okay, so when we go through this biopsy, we can see that it's an excellent biopsy. And the first thing that strikes one at low power is this blueness in the portal regions. You can see that there, you can see that there. And when you see blue in a liver biopsy, because as you know, the hepatocytes are eosinophilic, so when you see blue in a liver biopsy, you know automatically that that represents inflammation. We can also see that there's a little bit of fat as well, which is both large and small droplet fat. And that picture is replicated throughout the biopsy. So there's lots and lots of blue in this tissue. Right, so I'm going to stop and I'm going to show you this area here, because this is pretty representative. And when we go down and have a look at the portal tracts, you can see that we've got the vein, we've got the bile duct, and over here we've got the hepatic arteriole. So let's start then with the portal infiltrate. You can see that it is mononuclear, lots of lymphocytes, and intermingled amongst the lymphocytes, there are large numbers of plasma cells. And you can see these plasma cells here, and notice that the plasma cells, not only are they in the body of this infiltrate, but you've also got numerous plasma cells at the periphery. And one can see that there's an element of interface inflammatory activity. So for example, if we look there, you can see that we've got this infiltrate which is extending into the parenchyma, and I think that there is probably a suggestion of early hepatocyte necrosis, for example, there, where the hepatocytes are appearing a little bit more densely eosinophilic. We've got a few eosinophils as well in this infiltrate, and there's an eosinophil there. And then this is the bile duct. We'll talk a little bit more about that shortly. But also within this infiltrate, you can see that we've got plasma cells, and you can see that they are participating in this inflammatory, in this interface inflammatory activity. Now, the next thing I want to show you is this here. And there is a hepatocyte, and right next to it, there is a lymphocyte. And that lymphocyte is being engulfed by the hepatocyte, and we call that imperipolesis. Now, imperipolesis of lymphocytes, and in fact other inflammatory cells, but often lymphocytes, is a feature of autoimmune hepatitis. And it's found in up to 60% of patients who have autoimmune hepatitis. And in the early sort of 2000s, the thought was that this imperipolesis was a mechanism by means of which the lymphocytes induced hepatocyte necrosis. But the current thinking has sort of swung 180 degrees, if you like, because now the thoughts are that, in fact, what is happening is that the hepatocyte, in fact, destroys the lymphocyte. So if we go to sort of basic immunology, and I'm certainly no immunologist, and many of you will probably know more immunology than I do, but the principle is that if patients, for example, and we all have them, if we have lymphocytes that have autophagocytic function, in other words, autoimmune tendencies, I'm just trying to think of an appropriate word. There was one in the literature which escapes me now. But if the lymphocyte has a propensity to destroy host tissue, then the thymus is usually responsible for taking that lymphocyte out of the circulation and eliminating it by apoptotic mechanisms. But sometimes in an autoimmune disease, what happens is that the number of lymphocytes is overwhelming to the thymus. And then what happens is you get extrathymic, or the thought is that you get extrathymic apoptotic activity, so that these lymphocytes then, as far as the liver is concerned, are then phagocytosed by the hepatocyte, and they then undergo elimination as a result of the hepatic activity. And I'm going to talk a little bit more about that in the next case. So that's imperipolesis, And as I said, it's found in up to 60% of hepatocytes, of patients with autoimmune hepatitis. The problem is certainly that I find is it's difficult to sometimes decide, and there's a good example there. So if we look, for example, here, is that hepatocyte sitting in a sinusoid? For example, I think you can make out that there's a space there. That's probably a sinusoid. And it could well be that hepatocyte is in that lymphocyte is in a sinusoid rather than a hepatocyte. Whereas here, that may be the reverse. That lymphocyte could be in the hepatocyte. Here, it's pretty clear, in fact, that those lymphocytes there are sitting in a sinusoid. I'm not sure about that. There's a lymphocyte nucleus there in a vacuole, which is pretty close to that hepatocyte nucleus. So in peripolesis, although it's found most commonly in patients with autoimmune hepatitis, it is also found in other disease. It can be found in primary biliary cirrhosis, which, as we know, is also an autoimmune disease, but it can be found in patients with drug-induced liver injury and acute hepatitis. So it's not specific for autoimmune hepatitis, but one needs to recognize the fact that it can be found, but to a much lesser extent. For example, in drug-induced liver injury and acute hepatitis, it drops down to about 20% of patients. And before I move on, there's a nice focus there of interface inflammatory activity. And here you can see plasma cells participating in the elimination of that necrosis, of that hepatocyte. You can see this spotty necrosis. Right, before we lose, let's just move away now into the lobule. And here we've got, let's just orientate ourselves. You can see that we've got a portal tract there, and we've got another portal tract over here. So this is the lobule, and here we've got panzonal spotty necrosis or spotty inflammation, and that is resulting in spotty necrosis of hepatocytes. And if we look down there, we can see exactly that. We've got a hepatocyte there, which is surrounded by lymphocytic inflammation, and in some areas there'll be a few plasma cells as well. So we've got lobular hepatitis and portal inflammation as well with interface inflammatory activity. So when we grade it, we have a fairly simple approach here in Joburg. We always believe in trying to keep things simple, because if you don't keep things simple, I think one gets totally tied up in trying to sort out these minutiae. So we use the Metavir grading system, which is really just a scale of 1 to 3. You look at the extent of the interface inflammatory activity, decide how severe that is, whether it's 0, which is none, 1, which is mild, through to severe, which is a stage 3. And then together with that, you look at the lobular inflammation and assess the degree of lobular inflammation, whether that's absent, mild, moderate, or severe. So this would be equivalent to an A3, because I think you've got quite severe interface inflammatory activity, and you've got quite severe lobular inflammatory activity. So that is the inflammation as far as the plasma cells are concerned. And I think just looking at that, one can be fairly confident that this is autoimmune hepatitis. Now, there are some other features, and I mean, one of the things that certainly I've noticed, and those of you who are, seeing patients, but certainly my sort of feeling is that many patients, in fact, with autoimmune hepatitis go undiagnosed for one reason or another. And I think, subtle changes are missed, and hopefully I'll be able to show you some of those. I think this is, a fairly straightforward case to make the diagnosis. But then let's look at some of the other subtle features. So the first thing I want to go back to now is in the portal tract. And if we look at the portal tract, you can see in this bile duct that we've got loss of biliary epithelial cells. And there is a lymphocyte that is migrating, we call this inflammatory exocytosis, into the biliary epithelium. And that is a situation where you get almost like a lymphocytic cholangitis. And that can be found in patients with autoimmune hepatitis. It doesn't mean that the patient has concomitant cholangiopathic pathology. That may be a feature of this. Okay, so if you see, those of us who are histopathologists, always have a look at the bile ducts. If you think that there is autoimmune hepatitis, you must make a careful search for the bile ducts and assess whether there is bile duct loss. You may see bile duct injury, but that doesn't necessarily equate to bile duct loss. And in this particular instance, there was no evidence of bile duct porosity in any of the portal tracts. Right, what else can I say about this case? So the next thing is, I just want to show you this here. I think it's this one. Let me just have a look. No, it's not. That's another case. All right. So,
so Prof, they talk about resetting of hepatocytes.
Yes.
So resetting. What does that? Yeah.
So it's also supposed to be a feature of autoimmune hepatitis. There, for example, is a rosette there. Just quickly off the, I saw it and then it disappeared. But I think that might be a rosette there, where you've got hepatocytes around a central lumen. See if I can find some others. I find it quite difficult to decide, in fact, whether resetting is present or not. And I sort of ask the question, why is it just not hepatocytes around the sinusoid?
Yeah, because you know that was in the initial expanded autoimmune hepatitis criteria.
Yes, absolutely.
Yeah, I just find that it's less reported these days. And in fact, all you really need on the simplified criteria are the fact that you've got an interface hepatitis with a plasma cell predominance.
Yeah. So, you know, I think a lot of these things sort of get handed down from generation to generation, and they become mythical entities.
Canonized.
Yeah. So, for example, that there, you know, that could be a rosette. You see, you've got that central lumen there, and you've got the hepatocytes around it. But my question would be, well, why is that just not a sinusoid that's cut end on? You see, there's a sinusoid longitudinally section. So why not have one? Because I think we need, you know, one of the things that's important is that too often we look at things in 2 dimensions, forgetting, in fact, that it's actually a 3-dimensional structure.
Yeah.
So, yeah, so that's the resetting. And the other thing that I wanted to just, yes, there was endothelialitis in this particular patient. And endothelialitis is a feature of autoimmune hepatitis. So you need to look. So let's just see if I can get it. Yeah, here we are, going back to this one. So if we look at this here, you can see that there's the portal vein. All right, there's the portal vein. You can see the subendothelial aggregation of plasma cells and lymphocytes. And then we've got this space here. Look at this sort of bubbly appearance. You can see almost the subendothelial vacuolation and the lifting of the endothelial cells off the basement membrane. And sometimes, in fact, that can be so severe that the endothelial integrity is disrupted. So, for example, if you look at if we look at this one here, you can see that the endothelium seems to be intact there, but it looks as though it's probably disrupted in this region here. And here, I think there may be a bit of lifting as well. that's taking place. Now that's in the portal veins. And we must also remember once again that, we've also got the central veins to think about. And if we look at the central veins, so there's a good example of endothelialitis. I think this is probably a portal vein because it looks as though it's in close proximity to this portal tract here. But you can see the extent of the endothelial injury that's taking place. Look at all this lifting, okay?
Yeah.
And then this is the central vein here. But once again, you've got to kind of imagine where you are. So if I just put this under low power like this, so here we've got a portal tract, there we've got another portal tract, and there's the central vein, if you think of the classic lobule. And although you actually haven't got a vein in cross section, you've almost got this sort of fenestrated appearance. But this is the perivenular region, and you can see that there's extensive perivenular inflammation. It includes plasma cells. You can see plasma cells there. We've got red cell extravasation. So that's a wonderful example, in fact, of endothelialitis that we have with autoimmune hepatitis. There was no evidence of copper-associated protein and no porosity of bile ducts. So here's a very good example then of almost a classic autoimmune hepatitis.
Now that's fantastic. Thanks, Prof. So what we did with that information is that we initiated him on steroids. His ALT came down from 2,200 on the 20th of April. And on discharge, it was down to about 400 already. So a fantastic steroid response, which is then a further criterion in the autoimmune hepatitis scoring system. We're yet to follow him up, having been discharged just under 2 weeks ago. But I think I'm not sure if he's going to be followed up this week in clinic or early next week, but it is going to be sometime soon.
Yeah, that's good. Yeah, and I think that that sort of thing, that response to treatment is also a good diagnostic parameter to utilize.
Yeah. Who's our next case, Prof?
Next patient is TL.
Pat, I think you've got those details. He's one of Dr. Parbu's patients.
Okay, I'll come in on that one. Good evening, everyone. I'm Dr. Muchichwa. I'll try just to share my screen to see if we can go through the cases. Okay. Okay, can we see my screen?
That's it, yeah.
Yeah.
So Miss TL is a 69-year-old lady from Mozambique with background metabolic syndrome, extensive microvascular and macrovascular target organ damage, which is background hypertension, background dyslipidemia with an increased waist circumference. She had multiple admissions for septic complications and was referred by, excuse me, I just went quick there. Was referred for abnormal LFTs, which has been simmering with the GP for about 2 years. And the knee-jerk suspicion there was that of non-alcoholic steatohepatitis. So now the diabetic control had improved, the dyslipidemia had improved, with the expectations that with that, the NASH should improve. However, the LFTs remained unchanged, and hence was referred for a further workup. Her workup at presentation, we have the figures as shown, total bili9 conjugated of 4, the ductal enzymes, ALP to GGT of 211, 722, the transaminases, ALT, AST 135, 144, with a globulin gap of 45. Her IgG was increased at a level of 30, IgM of 0.7 with an IgA of 4. A synthetic function was normal in terms of INR. Autoimmune ANA was positive, high titers, 1:640. Anti-smooth muscle antibody also positive, 180 in 80. P-ANCA was also positive at 1:80. With this now bringing in a suspicion of autoimmune hepatitis. Viral studies was negative. The histology is going to be reviewed by Prof. Hale.
Okay, thanks, Ed. So I share the screen. Okay, so you should be able to see that. Can you see that?
Yeah, we can.
Great.
Thank you, Prof. We can.
Okay, right. So this then is a very similar picture, but there are some differences. So here you can see once again, remember I said that, here we've got blue portal tracts, and you can see that. You can see there is really quite massive expansion of all these portal tracts throughout the biopsy by this blue infiltrate, which we know, from previous experience is going to be is likely to be lymphocytic in time. And that's all the way through the biopsy. And I think that the other thing to recognize as well is that there does seem to be some change to the fibrosis. It looks as though there's a bit of portal tract expansion and probably early septum formation as well. So when we go through this, and we're going to have a slightly different emphasis in this particular one. So the first thing is that you can see, and I think you can see that, just focus this. That's a bile duct there. Yeah, so that's a bile duct there. And if we look here, we can see that at the periphery here, there's lots of small cells, and those are lymphocytes. So there is also an admixture of plasma cells as well. But I want to point out this area that appears lighter staining. And this is actually a germinal center. So we actually got follicles now that are being formed by this lymphocytic infiltrate. And when you see follicles like this in an that is almost diagnostic of autoimmune hepatitis. Obviously, we would have to think of other things such as involvement of the liver by follicular lymphomas and so on and so forth. But we're not discussing that today. So you see this, and we've got these lymphoid follicles. And there's another very good one up here. I think you can see the same sort of thing. At this magnification, you can see the mature lymphocytes, and in the center, you have these follicles there, which are composed more of centroblasts. And here you can see the mantle of mature lymphocytes at the periphery, and the follicle center there. And in fact, if you look there, you can see that actually is a mitosis as well in this germinal center. So that is a really textbook example of a follicular germinal center in a patient with autoimmune hepatitis. So let's look then at the rest of the infiltrate. So the first thing is that there are plasma cells, and very similarly to those that I showed you in the first patient. And if you look down here, you can see that we've got large numbers of plasma cells associated with that, with this interface inflammatory activity. And there you can see more plasma cells, for example, here, a group of plasma cells infiltrating in these interface regions. So that's a pretty good example of autoimmune hepatitis.
Yeah, no, that was fantastic.
And then, okay, but also, so now,
yeah, just in terms of the established follicles.
Yes, it's a classic example, isn't it?
Yeah.
And then
So just interesting with her is that they actually kind of assumed that despite the negative viral hepatitis studies, we're even questioning somewhat esoteric occult hepatitis B infection and NASH, and considering her ethnicity, that was thought not to be the case, and they kept on telling her go lose weight, without necessarily bringing in autoimmune hepatitis into the diagnostic consideration.
And I think, as I was saying earlier on, and I think we've seen this as well, is that many patients with autoimmune hepatitis are diagnosed late.
Yeah.
So this then is another example then where there's a slight deviation. So on the back of what I would call a classic autoimmune hepatitis, there are foci, and I know that there are some of the registrars, the histopath registrars, on the meeting as well. And I mentioned that you've always got to look at the bile ducts. So, and also have a careful look at the infiltrate, because one of the most important things is the overlap syndrome. Now, you're not going to get a diagnosis of an overlap syndrome in every single case, but you certainly do need to think about it. And if we look here, we've got this lymphocytic inflammatory cell infiltrate, and then we've got this area here that looks rather granulomatous. And if we look at some of these cells, so the registrars here know that I call these cells Cook sister cells. And why do I call them Cook sister cells? Because those of us who live in South Africa, or not necessarily live in South Africa, but those of you to the north of us, I mean, certainly we used to eat Cook sisters up in Zim. And the Cook sister, as you know, has two cords of pastry or dough intertwined together, and they have this sort of appearance that looks a bit like that. So you could imagine that that's one cord of dough and another one sort of twined around them. So I like to always bring a sort of a local sort of flavor. We talk about donut cells, we talk about breast cancer cutting like a ripe pear and what have you. And I think that Cook sister cells is a pretty good analogy for a local name for a worldwide entity. So these are epithelioid histiocytes, and this looks granulomatous. There's no caseation. You've always got to think of TB, you've always got to think of sarcoid, and so on and so forth. But in this context, one has to think of, could this be an overlap syndrome? So the next thing you do is say, okay, well, let's see if we can see bile duct injury. And if we go to this region here, you can see that we've got a bile duct here. And when we have a look at this duct, we can see that I showed you last time there was some lymphocytes, and there's a lymphocyte there. And I think that may be an epithelioid histiocyte. But if you look here, these are histiocytes that seem to be attacking the biliary epithelium. Now, as I recall, Pet, I don't think that the PBC markers, I think, were negative in this particular patient, recognizing that they can turn, they can be negative at presentation, and they can become positive later on. So this is, I think, fairly conclusive evidence that we've got a potential evolving overlap syndrome with primary biliary cholangitis. So remember, those of you who are writing your exams, we don't talk about this as primary biliary cirrhosis anymore. We call it primary biliary cholangitis, and that's a much more appropriate term. Okay, it's not you get biliary cirrhosis, yes, but in fact, it's an inflammatory mediated injury to the bile duct. And if we look at these bile ducts here, you can see that there is also an abnormal architecture to those bile ducts. Look at the biliary epithelial loss. And these are all things that I always say that the slides have got to tell you a story, okay? And they've got to speak to you. And this is the sort of thing that it's telling you. I'm under pressure. That's what this bile duct is saying. And why am I under pressure? Because of these epithelioid histiocytes at the periphery. And that picture is replicated. And there again, is another bile duct. Okay, and you can see this bile duct here, you can see there's a bit of vacuolation. There's a lymphocyte here, but in close proximity, one's got these epithelioid histiocytes at the periphery. So one ignores the possibility of overlap syndrome at one's peril. And if you look at this bile duct here, you can see here it's starting to appear quite irregular. There's an epithelial attenuation. Also note that there's no evidence of periductal fibrosis, okay, because primary sclerosing cholangitis can also be part of the overlap syndrome with autoimmune hepatitis. And look again there, okay. So now when you see bile ducts that are under threat like that, you then need to say, well, have the bile ducts disappeared? And I don't want to spend too much time looking for bile ducts, but then when you look at this portal tract here, okay, you look at that portal tract there, and there's no bile duct, it's gone. Okay, and then if you come up here, we've got a large portal tract, for example, down there. There's the hepatic artery there, all right, there's the bile duct. Where's the, the portal vein? You have to say, well, where's the bile duct? Because the bile duct should be of the similar size to the hepatic artery. And we've got this broad expanse of portal tissue. In fact, there is a bile duct there. But I certainly would like to see, you know, probably another bile duct in this region here. So anyway, the next thing we did was we looked for the CK7. And the CK7 so the CK7, we counted the portal tracts and the bile ducts and that sort of thing. And let's just focus on this here. So you got two portal tracts, portal tract there, there's a portal tract there. And the CK7, how do you recognize a native bile duct? Well, it can be difficult, but I think you've got to be pretty strict. And a native bile duct you want to see is regular, smooth outline, such as you see there. So I think that's a native duct, that's a native duct. These are all proliferating bile ducts, okay? So they don't form part of the equation. When we look at this portal tract here, you can see that there is no native bile duct, it's been lost. And when we do a count, we find that, as I recall, there were, I think, 16. There were 21 portal tracts, and only 16 of them had bile ducts. So the ratio of bile ducts to portal tracts is markedly reduced. Then the next thing I want to show you is just going back to the H&E. There's a little bit of fat. And there was more fat in the previous one. Yeah, I'll just show you quickly the previous one. Of course, there's a little bit of fat here. And I just want to mention that sometimes you get steatosis associated with autoimmune hepatitis. And Bilal, you may want to comment on that about your patient. So that fat there may not necessarily be because of the metabolic syndrome. It may be because of the autoimmune hepatitis. Right, now I want to look at the immunohistochemistry on the subtyping of the. So we're going back now to this particular patient, the current patient, and this is the CD20, and you've got this strong positive staining of the germinal centers, okay, which is what you would expect. And in the portal tracts where there's no germinal center, such as there, you can see that the number of B cells is considerably reduced. Okay. And then when we look at the CD3, the CD3 is strongly positive, as one would expect. As you see there, lots of CD3 positive cells. And then when we look at the subsets, I'm going to show you first of all the CD8. Now, we spoke about imperipolesis. And what has been established is that the CD8 cytotoxic cells are in fact usually major participants in the interface inflammatory activity. And if you look there, you can see how ragged this interface is, okay, because these are all the CD8 positive cells. So you've got CD8 positivity. And when we talk about the peripoiesis, it's been established that those lymphocytes that are undergoing peripoiesis by hepatocytes are in fact CD8 positive. So that's then a good example of CD8 positive interface inflammatory activity. And then when we compare that with the CD4, just pick up a random portal tract. So we can see that the interface here, okay, so this is the interface, you can see that's smooth, much smoother on the CD4 staining compared to the CD8. So that tells you that the CD8 stains is primarily responsible for the interface inflammatory activity. And then the 38 to show you the plasma cells, CD38, large numbers of plasma cells in that I showed you earlier on. And then last but not least, the stains, I showed you the CK7, and I want to show you the P16. Now, P16 is a marker of cellular senescence. You need to think about P16 as being the brake on cell cycling, all right? So you've got the cyclin-dependent kinases, which, if you like, are the accelerator for cell division. And whenever you get acceleration taking place, the reverse brake comes on, which is a number of them, and P16 is one of them. And this is P16. And if we look down here, for example, we can see that we've got a native duct. Only look at the native ducts, okay? Don't look at the proliferating ducts, because I think the proliferating ducts are going to be dying anyway. But if you look at the native duct there, for example, you can see a native duct there. You've got cytoplasmic and nuclear staining. So that tells us that we've got nuclear senescence or cell senescence going on. And there's a little bit of copper-associated protein in this biopsy as well. And copper-associated protein is associated with chronic cholestatic conditions, and there's the copper there. So I suspect that this patient, if the serology is negative, I suspect that this is going to be an evolving PBC overlap syndrome with autoimmune hepatitis. So, Pet, yeah, long story, but I think a very interesting case.
Absolutely. And I'm glad that she's eventually gotten diagnosed with it. Who's our next case, Prof? Just in the interest of time, we've basically got another 15 minutes left.
Yeah. So let's do AG. Also,
Pat, is that on you?
One of Denon's patients.
Okay. I'm not sure if you can see my screen.
Yeah, there we are. Can, yes.
Okay, so Mr. AG.
No, Pat, I can't see your screen yet. Can you share?
Okay, let me see. Escape there. But can you see me?
I can see you.
Okay. Let's see if I can do that. Does that come out?
That's better. Yeah.
That's better.
So just at presentation mode.
Okay. So Mr. AG 16-year-old male who has acne. As part of the blood workup, they found out that he had abnormal liver function tests. Of note from the history that there was no significant past medical history besides the acne that he was presenting with. No allergies, there was no ethanol use in the background, denies any herbal use or any over-the-counter medication. No really significant travel history to note, and then there were no occupational exposure. Here is the liver function test spanning a period of about 4 months from the bilis, which has been settling now. Also the ductal enzymes with the transaminases. Synthetic function largely unaffected. Also IgG in December noted to be high at 24. Essentially, this is a summary of the liver function test over a period of 4 months as well from the referral. Additional workup, we had negative viral studies, including CMV, HSV, also EBV. As a young person, Wilson was considered, workup was negative. Autoimmune screen, ANA, noted to be positive, high titers 320, homogeneous in pattern. Smooth muscle was also noted to be positive, titers 120. IgG, as noted earlier, 24.7. Other workup, liver, kidney, smooth muscle, LC, all negative. ANCA was also negative. Prof has histo to discuss.
Okay. Right. So what I'm going to show you now is another variation on the theme. So I'm not going to dwell too much now on the sort of the specifics of autoimmune hepatitis, but rather to show you some of the variants and the changes. So this patient then also has pretty good features of autoimmune hepatitis. One can see that you've got the blue portal tracts as you've got there. And when we have a look, one could almost suspect that there may be a bit of germinal center formation. And in some areas, there are plasma cells. And for the registrars, plasma cell clustering is always an important sort of diagnostic clue. And here we've got a group of 3 or 4 plasma cells. And if you've got plasma cells participating in the interface inflammatory activity, that's almost diagnostic, I think, that you've got autoimmune hepatitis. So this patient has autoimmune hepatitis, and there's emperipolesis as well in this particular patient. Now, in some areas, there are epithelioid histiocytes again. And if we look, for example, in this region here, one can see that we've got the bile duct there, and then we've got these twisted sort of nuclei, the so-called Cook sister cells. And, you know, could this be an evolving cholangiopathic pathology? There is another area there. You can see that we've got almost the beginnings of a lymphoid follicle, and we have a bile duct there, and we've got some of these sort of cells there that have a little bit of an epithelioid quality to it. So anyway, when you go through the H&E, there's a bit of lymphocytic inflammation in zone 3. So that's a fairly typical example then of autoimmune hepatitis. And there again, I think if you look at this, you can see that there's beginnings of germinal center. You've got endothelialitis, and you've also got lymphocytic inflammation that is inflammatory exocytosis into the bile duct epithelium. So remember, as I said, that, you know, often you get this in up to 24% of patients who have autoimmune disease. Now, in this particular patient, I'm not going to bore you with going through the whole lot again, all those features, but just to show you there, for example, there are a couple of bile ducts, and you can see there's quite extensive lymphocytic inflammation. So I've got quite a cholangitis. Then when we look at the CK 7. And it's always useful to have these cells, because at least these slides, because in cases, because sometimes you just sort of doubt your own diagnoses, and are you overcalling things or what? But this is the CK7, and I showed you what the normal bile ducts look like. And here you've got, for example, that's a nice round bile duct there, but you've got quite florid bile ductular proliferation. Given the fact that we know that there's lymphocytic cholangitis, that's not surprising. But when we go through all these portal tracts, you can see that we've got native bile ducts that are present in all the portal tracts. So there's no evidence of bile duct porosity. Okay, there again, these are these native ducts. And then when we look at the CK7, when we look at the CK7, in contrast to the last case, there is absolutely no evidence of positive staining of biliary epithelium. So there's no biliary senescence. So although it looks as though there may be cholangiopathia pathology, there is in terms of the ductular proliferation and the lymphocytic cholangitis. But we know that can occur in the absence of PBC. So I just want to show you some of the bile ducts. Always difficult to look at negative immunohistochemistry. There we are. Okay, so there's a bile duct there, and you can see it's fine. All right, but if you search through those bile ducts, there's no evidence of any staining. So that then is a patient who's got autoimmune hepatitis, no bile duct loss, but has got sort of lymphocytic cholangitis. So that's that patient. So let's, shall we do one more, Bilal, quickly?
Yeah, let's try and get we've got 5 minutes.
Yes.
Do you think we can squeeze it in?
Yes, I can, yeah.
Okay.
Plenty time, Bilal, plenty time.
Right, okay.
We can go over a few minutes. It's not
okay. Well, then maybe I should do Riza Carr. Sorry, not should mention the name, RK.
Yeah, so Miss RK is an interesting patient. She was initially diagnosed in about 2014, 2015 as a suspected patient with a drug-induced autoimmune hepatitis. She had taken a course of ketoconazole that is a recognized cause of this. She had a positive ANA at the time, and she was subsequently treated with immune suppression for a period of time, after which she defaulted or stopped following up and stopped her medication on her own accord. She then came back to our clinic in about 2018, and at this stage she was off all therapy for a year and a half, and her immunoglobulins, LFTs, were all normal. We elected at that stage not to put her back onto any therapy and not to biopsy her either. She then once again didn't follow up as we hoped she would, only to reconsult one of the other team members in the practice, where she was consulted again for an autoimmune type picture. This time the ANA was quite positive, elevated IgG, and a biopsy was performed once again. This time there was no specific drug exposure.
Okay, you have to please correct me if I'm wrong, Bilal, but ketoconazole also causes bile duct porosity, doesn't it?
Yeah, I think it does, yes.
So I wasn't aware of that. That drug history. So, right. Get my ducks in a row here. Sorry, I just got to make sure I get the right slides in the right place. Right, so this is her biopsy, and what is interesting about this, once again, it's a blue biopsy from the point of view of the portal tracts. I'll share the screen. So there is the duct, and you can see the familiar theme, okay? This expansion of the portal tracts. And then when we look at this, we can see that it's lymphocytic. And once again, we've also got plasma cells that are participating in the inflammatory process. Not as many as in previous cases, but certainly you can see, for example, down here, there are a few plasma cells. So this is another example of autoimmune hepatitis. And then when we look, and this is actually an interesting one, because this is an interesting debate now below, because if we look, for example, at the bile ducts, we can see that there is evidence of epithelial injury. You can see that there. There's a bile duct. You can see the cytoplasmic vacuolation and loss of biliary epithelial cells. You can see plasma cells up at the top here. But there are portal tracts here where there is an absence. And let's just show you this. There's a plasma cell there sitting. Where has it gone? There's a plasma cell there sitting in the parenchyma. So there's a portal. No, that's not a good one. So there's a portal tract. We can see the vein, we can see the artery, there's no bile duct. A couple of plasma cells. So question now is there porosity? And the answer is yes, there is porosity. This is the CK7. And when we look at the portal tracts, you can see, for example, that this is ductular proliferation, and that native bile ducts are markedly reduced. So there's a native duct there with bile ductular proliferation, and there were 41. There were a couple of cores in this biopsy, but there were 41 portal tracts and only 27 bile ducts. So, or 27 of them showing bile ducts. So the question then arises, is this bile duct porosity due to ketoconazole, or is it due to the autoimmune process? Now, I don't think we'll be able to answer that. Interesting.
Yeah, no, absolutely. So I think that is going to be it for. I've
got one more quick case. Quick case.
Okay. Go for it, Prof.
Okay. So this is MF. Don't worry.
Okay, so this.
Do you know the history? Just a brief history.
Let me get this up for you quickly. So let's see. This is a young lady that was referred through from the rheumatologists with a background of possible Sjogren's syndrome. She was already on plasmapine at that stage. They, however, picked up that she was developing ascites, and a transjugular liver biopsy was done for her. In terms of her bloods, she had a very mixed picture: alkaline phosphatase 184, gamma of 136, ALT 126, AST 97. She had a significant globulin gap with a total IgG of 28.6. Her ANA was positive, titer of 1 in 160. The rest of the autoimmune workup was negative.
Great. Thanks, Bilal. Right, so this one is really just a quick one. And I always say as well that, sometimes I think histopathologists were a little bit too quick to say the biopsies are suboptimal and you can't make a diagnosis. But you've always got to take...
Prof, that screen is very small at the moment.
Yeah, it is. Yeah, it's a tiny biopsy.
Oh. Okay.
It's a tiny biopsy. So this is what we got, the transjugular biopsy, and they are, because of the nature of the procedure, very difficult biopsies, and they're tiny. So you have to make do with the best that you can. And you've got to look at everything. You've got to look at the history, the lab investigations, and so on. Anyway, so we know that she's got features of autoimmune disease. Here we've got this portion of tissue, and there you've got this pretty, I think this is probably this area here, this is probably portal. It's fragmented because A, the biopsy, and B, because of the fibrosis in the biopsy. But you've got this inflammatory infiltration, spotty inflammation in the lobules, and that's certainly consistent with the history and the labs of autoimmune hepatitis. She's got an elevated IgG, she's got other connective tissue diseases. But really what I wanted to show you is this here. And as you said, it's a tiny biopsy, but this is large cell dysplasia. Okay. And, I just really wanted to say that.
Prof, can you, that picture on my screen I know is absolutely minuscule. It's not our normal presentation screen.
Okay.
Can we maybe large format it so you can point out that dysplasia?
Can you see that picture?
Tiny again.
Tiny. How's that? Let me exit full screen. Let me go to full screen.
I can see it clearly, Bilal.
Oh, can you see it clearly? Okay, I don't know why on my screen it's tiny.
Load shedding.
All right, Prof, go ahead. Go ahead.
So look at this variation in cell size, nuclear size. See that? And you got this inflammation as well. So really, I just wanted to show that, don't write things off, particularly from the point of view of the pathology people. And, every little bit of information that you get is important. And as I was saying at lunchtime, it never ceases to amaze me how sometimes you get, even in the tiniest biopsies, pathologically significant information. So that's a case of patient with autoimmune hepatitis and large cell dysplasia. And that's important because, as we know, these patients need to be followed. And that's it from my side.
That's brilliant, Prof. Thanks so much. Whenever you initially start reading these biopsy reports, I know they can be quite intimidating, trying to go through the different language, looking at things such as what we spoke about in terms of resetting and so on. And I think your explanations were absolutely fantastic, as pointed out by others in the chat. I would like to thank Dr. Machitra, who helped present the cases, to the ECHO University of New Mexico team and ECHO India team for allowing us to use this platform. Feedback form, of course, is in the chat, and recordings will be available on the Gastro Foundation website. Thanks, of course, to the Gastro Foundation for hosting us. Next week will be a session on pediatrics. Tim, are you on for that?
Yep, I'll be there.
Yeah. What's the topic?
Primary intestinal lymphangiectasia, which I'll have to read up about myself, I'm afraid.
Yowza. Okay, good luck. So that sounds like something that I certainly can't say I know too much about. So hopefully we'll be on for that as well. Prof Hale, thank you so much for a wonderful presentation again and taking us through that true tour de force. Looking forward to seeing everyone next week. Cheers. Bye-bye.
Thanks, Bilal. Thanks for inviting me.
Thanks, Martin. Thanks,
Okay,
Bilal.
pleasure. Thanks, everyone. Keep well. Cheers, then.